Dear students, good morning. I am Assistant Professor Dr. Harra. Our lecture today is the etiology of malocclusion. In this lecture, we will give an information about definitions, classification and prevalence, general factors, and local factors. What is the objective of our lecture today? As we know, there is a response for each stimulus, and this response is followed by a consequence. So good knowledge of this consequence will aid in identifying the underlying stimulus, thus help in either elimination or exaggeration of the response. For each orthodontic patient, robust treatment plan can be achieved after comprehensive clinical examination associated with history taken from the patient. Thus, all these data and problem list diagnosis lead to robust problem list evaluation and thus aid in treatment planning for any orthodontic patient. As we see here in this diagram, problem list and diagnosis, any pathology or cause for such malocclusion should be well identified either during history taking or by clinical radiographical examination of the patient. So, any cause for this malocclusion either should be controlled before treatment or maintained during treatment. This is the objective in order why we should know the etiology of malocclusion. This gives the answer that we can get a robust problem list and aid in diagnosis and a robust treatment plan for such patient. Here in this slide, I just want to remember you that the clinical examination for any subject should be done in 3 planes of space. These terms will be used in the lectures later, so that the transverse plane, which is the yellow one in this color, and the anteroposterior in red, and the vertical one in green. So please be remembered these planes of space. So after we know the objective of our lectures, then we will do a refreshment for the definitions, classification, and prevalence of malocclusion. Occlusion versus malocclusion can be defined as the literal meaning of occlusion means closing. In a dental context, occlusion means contact between teeth, or more technically, the relationship between upper maxillary and lower mandibular teeth, as occurs during rest, static, or movements dynamic. While malocclusion is a developmental condition, in most instances, malocclusion and dentofacial abnormalities are caused not by some pathologic process, but by moderate, occasionally severe distortions of normal development. Also, we can remember the classification of malocclusion, that is specified by angle that in spite of its limitation, but it is widely accepted and used till now. As we see here, there is a normal occlusion in which the mesobuccal cusp of the upper permanent first molar occlude in the buccal developmental groove of the lower permanent first molar. This normal occlusion can be accompanied with malocclusion, as we see when there is a malocclusion as crowding or spacing. This condition is named as a class 1 malocclusion, in spite of molar relationship is the same as in the normal occlusion. While class 2 malocclusion, the mesobuccal cusp is a more forward relation to the buccal developmental groove of the lower permanent first molar, while in the class 3 malocclusion, this mesobuccal cusp is in a more distal relationship to this developmental groove. The prevalence of malocclusion. It is difficult to know the precise cause of most malocclusions. These problems most often result from a complex interaction among multiple factors that influence growth and development, and it is impossible to describe specific cause for malocclusion. As we see here, in a study and a survey in US population, we see that only 5% of patients with the malocclusion they got the non-cause of such malocclusion, while 60% of patients the malocclusion cause was unknown, and only 35% with the normal occlusion. The final form of the occlusion and position of the teeth exhibits a wide range of variation. Therefore, the main factors responsible for producing this variation can be divided into two main groups. According to Graeber, the main etiological factors of malocclusion can be classified into either general or local factors. The general factors including hereditary genetics, congenital, environmental, predisposing metabolic disease, dietary problems, abnormal pressure habits and functional problems, trauma and accidents. While the local factors including anomalies of number, anomalies of tooth size, anomalies of tooth shape, abnormal labial frenum, premature loss, prolonged retention, delayed eruption of permanent teeth, abnormal eruptive path, ankylosis, dental caries, improper dental restorations. All these factors could lead to develop of malocclusion. So in the general factors affecting the occlusal development, as we said previously, these factors all together may be one factor or more than one could lead to either skeletal factors that affecting on the occlusion and resulting in malocclusion, or soft tissues and neuromuscular system that also could lead to a malocclusion, and finally the dental factors. So now we should know that there are three main factors that should be identified in the clinical examination and history taking from the patient, either related to skeletal factors, soft tissue factor, or dental factors. All these considered to be as a general factors. First of all, we are talking about the skeletal factors. Excluding any pathological condition, the teeth are supported by the alveolar bone, which in turn is based on the basal bone of the jaws. Therefore, jaw bone can be subdivided into alveolar bone, as we see here, in the maxilla and in the mandible, and the basal bone, which is the maxilla for the maxillary arch and the mandible for the mandibular arch, although both of them are belong to the same bone. And we see here there is also the relation of these bone to each other and to the cranial base. As the teeth are set in the jaws, the relationship of the jaws to each other will influence the relationship of the dental arches. As we see here, the head bones, including the cranial base, the maxilla, mandible, and the dentoalveolar bone that the teeth set on it in the upper and lower arches. So jaw relationship can be considered as the following. First, jaws in relation to the cranial base and to each other. Jaws are part of the head. Therefore, each jaw may vary in its positional relationship to other structures of the head. Such variation can occur in sagittal, lateral, and vertical planes. In orthodontic diagnosis, it is usual to relate the position of upper and lower jaws to the anterior cranial base, and each jaw can vary independently in its relation to the cranial base. Also, jaws in relation to each other can also vary in these three planes of space, which is sagittal, lateral, and vertical planes. And variation in any plane can affect the occlusion of the teeth. As we see here, the sagittal anteroposterior relationship of the upper and lower jaws to each other called the skeletal relationship or skeletal pattern of the patient, which can be divided into three main classification, which is either skeletal class 1, in which the jaws are in ideal anteroposterior relationship in occlusion, in normal position in relation to each other and to the cranial base. While in skeletal class 2 pattern, the lower jaw either protruded in relation to the cranial base and normal positioning of the maxilla, and this is named as skeletal class 2 pattern type 1, while in skeletal 2 pattern type 2, the normal positioning of the mandible is occur with the maxillary protrusion, resulting in skeletal 2 pattern type 2, while in the skeletal pattern 2 type 3 there is abnormal relationship of each jaws to each other and to the cranial base. As we see here, there is a maxillary protrusion and mandibular protrusion that resulting in such pattern. In the patient with skeletal pattern type 2, the face of the patient in the profile view give us a convex profile, while in skeletal pattern 3 type 1, it is occur either one of these three positioning and relationship of the jaws to each other and to the cranial base. As we see here, either it is occur due to maxillary protrusion and normal positioning of the mandible, or normal, and this is named as skeletal pattern 3 type 1, or normal positioning of the maxilla with the mandibular protrusion. This is type 2, and in type 3 there is also abnormal positioning and relationship of the jaws to each other and to the cranial base. In such pattern, skeletal pattern, we see this the patient profile will be in a concave profile view. As we see here, clinically, when examine the patient to know the main cause and etiological factor of the relationship of such a relationship and malocclusion, the class 1 skeletal class 1 pattern, there is a nearly straight line, and in the class 2 there is a convex profile, while in the class 3 there is a concave profiling. Also, variation in the size and position of the jaws, in addition to the relationship of jaws to the cranial base and to each other, resulting in a malocclusion. So, in the sagittal plane, if one jaw is excessively small or large, as we see here, this is a small mandible, and while here there is a large mandible. So, in relation to the other in anteroposterior dimension, the development of a skeletal class 2 or skeletal class 3 relationship may result. In the diagnosis and problem list evaluation and initiation after clinical radiographical examination of the patient, firstly we should name the skeletal pattern of the patient. Either we said skeletal class 1, skeletal class 2, either type 1, type 2, type 3, or skeletal class 3 as well as type 1, type 2, type 3. And then after evaluating and identification of the skeletal pattern, we will list the other problem list, either dental or soft tissue problems. Please be precise in your clinical examination and in identifying the main skeletal pattern. And any patient with abnormal skeletal pattern rather than class 1 should be examined radiographically and as well as clinically. In the vertical plane, the effect is mostly seen with the variation in the shape of the lower jaw at the gonial angle. As we see here, this is the gonial angle, and any variation in the gonial angle will resulting in either if it is increased, the vertical dimension of the face increased, as we see here, the gonial angle is increased, this resulting in increased in the lower facial height, while if it is decreased, there will be a decrease in the lower facial height. In lateral plane, intraorally, if the jaws match in size, then the occlusion of the buccal teeth in transverse relation is correct, but if one jaw is wider than the other, it may result in buccal crossbite. When the lower jaw wider, or scissor bite when the upper jaw is wider. As we see here, when the upper jaw smaller than the lower jaw, so there is a buccal crossbite, while when the upper jaw is larger than the lower jaw, there will be a scissor bite. The alveolar bone relationship to the basal bone. Although the alveolar bone is supported by the basal bone, as we said previously, this is the alveolar bone supported by the basal bone for both maxilla and mandible. And the relationship between the upper and lower bones is not necessarily the same as that between the upper and lower basal bones. The alveolar bone supports the teeth and will therefore match tooth position rather than basal bone position, as we see here. Even though there is a protrusion in the maxilla basal bone and protrusion in the mandibular basal bone, but the alveolar bone in a normal positioning for both jaws. While in this condition, there is a protrusion in the maxilla and protrusion in the mandible basal bone. Also, we can see there could be normal relationship of upper and lower alveolar bone. This is named as a compensation for the condition, for the underlying malocclusion and developmental skeletal abnormal skeletal pattern. So, therefore, the alveolar bone, as it supports the teeth, will therefore match tooth position rather than basal bone position. So, after a comprehensive examination of the skeletal factors and the relation of each jaw to the cranial base and their relation to each other, and the relation of the alveolar bone to each other and to their supporting underlying basal bone, also any variation in the size and position of the jaws should be evaluated. All these could lead to identify the cause and the etiology of the underlying malocclusion. Then, soft tissues and neuromuscular system should be examined and to identify any relation of any abnormality in such soft tissue that's surrounding the teeth and leading to any abnormal positioning and a relationship and occlusion of the upper and lower teeth. As we know, the teeth erupt into an environment of functional activity governed by the muscles of face, mastication, and tongue. The muscles of the tongue, lips, and cheeks are of particular importance in guiding the teeth into their final position, and variation in muscle form and function can affect the position and occlusion of the teeth. All muscles exert their influence by their sites of origin and insertion. Since the origins of these muscles are mainly on the basal bone, therefore the position of the jaws must affect the position and action of the muscles which function on the teeth. As we see here, the tongue of this patient have large tongue, which is named as a macroglossia, and the tongue ridging can be identified easily by asking the patient to protrude the tongue, and we can identify that the underlying malocclusion could be related to such soft tissue problem. Firstly, we will talk about the lips. Lips should be examined carefully. As we know, several muscles of the lip work as one functional unit. Their effect on occlusion development depends on their form, size, and function. So, in the vertical relationship of the upper and lower lips, the ideal lip form, the lips meet together at rest position. This condition called the competent lips. If the lips don't meet in rest position, so a condition due to short upper lip, seal achieved only by active contraction of the orbicularis oris and ventralis muscles. This is called lip incompetence. Sometimes another condition when the lip seal is prevented due to malocclusion. For example, as we see in this picture, there is protruding maxillary teeth and despite normally developed lips. This is called potentially competent lips. Lips are usually brought together during swallowing and speech movements. If they are of sufficient size to be together at rest, then lip closure will not place extra force on the teeth. If the lips at rest are apart, then muscular contraction will be required to bring them together during swallowing and speech, which in turn will impose extra forces on the erupting teeth. The effect of these forces on the erupting teeth depends on the sagittal relationship of the lips. In the sagittal relationship, it is determined by the relationship of the basal bone of the jaw to which they are attached. For example, the lower lip tends to be further back in class 2 and further forward in class 3, which increase the difficulty to put the lips together and may cause the lower lip to modify the eruptive path of the incisors. In skeletal class 2, the lower lip may function completely or partially behind the upper incisors. For example, in not severe cases, the lower lip may procline the upper incisors, resulting in more severe class 2 than skeletal relationship. In more severe skeletal discrepancy, the lower lip may function behind the upper incisors without causing them to be proclined. In other skeletal class 2, the lower lip function entirely in front of the upper incisors, causing them to be retroclined into the class 2 diff 2 incisor relationship, as we see in this female patient. While in the majority of class 3 malocclusions, the soft tissue don't play a major etiological role. In fact, the reverse is often the case, with the soft tissue tending to tilt the upper and lower incisors towards each other, so that the incisor relationship is often less severe than the underlying skeletal pattern. This dentoalveolar compensation occurs in class 3 malocclusion because an anterior oral sear can frequently be achieved by upper to lower lip contact. This has the effect of moduling the upper and lower labial segments toward each other. Also, the lip line should be examined carefully to identify any relation of the lips to the underlying malocclusion. The level at which the lips meet together in normal function, which is different from the smile arc, as we see here in the picture below. The smile arc is the line that follows the curvature of the lower lip during social smile. While the lip line, as we see here, the ideal lip line is approximately at the center of the crowns of the upper incisors, with the lower lip in front of the upper incisors. If it is low, part of the lower lip may function behind the upper incisors, causing proclination, while if it's completely behind upper incisors, there will be no lip line as in class 2. If it is high in class 2 diff 2, causing retroclination of the upper incisors.